Shoulder dislocation is a common injury in sports or activities that involve high-velocity injuries such as skiing or other contact sports. The most common injury is the anterior-inferior dislocation. Reduction of this injury in the acute setting improves patient comfort and reduces risk of neurovascular injury. The patient presents in acute pain, often holding the affected side in flexion and internal rotation. If appropriate monitoring is available, sedation can be useful to provide better muscular relaxation and patient comfort. However, the longer the dislocation is in place, the greater the spasm that develops. Reduction can be accomplished without sedation in many cases. There are several methods to reduce this dislocation. The general principle is to rotate the humerus externally with slight extension of the humerus to dislodge it from the inferior aspect of the glenoid fossa. In patients with poor muscular development, simple external rotation or extension may be enough to relocate the shoulder. Scapular rotation, rotating the glenoid fossa downward towards the dislocated humeral head, may also work in similar patients. In athletic patients, the technique combining steady traction to fatigue the rotator cuff spasm and slight external rotation is highly successful. Place the patient in the supine position with a sheet or clothing wrapped underneath the affected axilla crossing over the chest. The assistant stabilizes the patient's torso with traction. Grasp the affected arm with one hand above the wrist and one hand above the elbow at the base of the humerus. Apply gentle traction to the arm at a 45-degree angle from the trunk in slight extension. If crepitus is felt or heard during traction or rotation, stop the procedure and obtain an X-ray. If there is history or exam findings that suggest a humeral fracture, do not attempt relocation before X-rays are obtained. As the deltoid fatigues, gently externally rotate the humerus about 15 degrees. When the muscle is adequately fatigued and the rotation completed, the humerus will relocate back into the glenoid fossa. The patient will note immediate relief of pain. Hold the arm close to the patient's chest and place in a sling for 14 days to protect the shoulder from repeat dislocation. All patients should have rehabilitation for the shoulder to prevent recurrence of the dislocation.